dear postgraduates, last class we discussed about the rheumatoid arthritis, its prevalence, its incidence, its pathophysiology, etc. Today topic will be on the management of the rheumatoid arthritis. This is one of the very important topics for the physicians because every day we see a lot of the rheumatoid arthritis cases and your treatment should be different from a general practitioner. So you need to understand the management of the rheumatoid arthritis from the day one, how to prescribe it and what is the long-term effects and how to monitor it and when to stop. So all these things in the next few minutes we would like to discuss about these things. See, what are the goals of the management? It's focused on the relieving the pain. So the pain relief is very, very important. So because asymptomatic, these people are very, very symptomatic, rheumatoid arthritis. So you should make them asymptomatic as early as possible to relieve the pain. And the second important thing is as a physician, so it's our duty to prevent the damage and the disability. So I have shown you some pictures last week about the rheumatoid arthritis, extensive rheumatoid arthritis or severe rheumatoid arthritis. So we should not allow our rheumatoid arthritis people to go into that deformities or the damages. And obviously for any chronic disease, education is very, very important. So the patient education about the disease is very, very important. So what are all the causes for the rheumatoid arthritis? How it happens? What are the treatment modalities? And what are the role of the biologicals, etc. So the patient education is very important for all the chronic diseases like rheumatoid arthritis or other connective tissue disorders or the diabetes or hypertension or IHD or CKD or interstitial lung diseases, bronchial asthma, COPD or acute chronic pancreatitis, etc. So they need the education. So please spend some more time. Whenever your diagnosis is a chronic disease, so definitely you have to spend some time on the education of the patient. Physiotherapy is very, very important for all the communicable, all the connective tissue disorders. So the physiotherapy for stretching and the range of the motion exercises. Occupational therapy for the splints and the adaptive devices. And the most important point here is treatment should be started early and it should be individualized. So you have a lot of the DMRDs and the biologicals. So it's up to you to decide. So which drug you are supposed to use as a monotherapy or the 2 drugs or the 3 drugs or the biologicals, etc. And always an early and aggressive treatment is very, very important to avoid the second thing. That is to prevent the damage and the disability. So you need an early and aggressive treatment and also treatment should be started much early and also it should be individualized. So these 3 are very, very important. Early treatment, individual treatment, aggressive treatment is almost needed from the physician's point of view to prevent the damage and the disability. Say for anyone to relieve the pain because they write a lot of the NSAIDs and also they write the steroids. The patient obviously will get the asymptomatic and then painless. But what about the damage and the disability? So unless you treat with the DMRDs, so definitely lot of the damage and disability will occur in those people. Not only that, the mortality also will be much higher. As I told you in the last class, rheumatoid arthritis individuals, the chances of ischemic heart disease, the chances of the arrhythmias, the chances of the liver failure, the chances of the CKD, the chances of the ILD, these are all also very high because it's a systemic disease and you also have a lot of the extra-articular manifestations of the rheumatoid arthritis. So control the inflammation. So that is a fundamental concept of the rheumatoid arthritis treatment. So detect early. Yes. How to detect? You know. So before your rheumatoid factor, anti-CCP antibodies will be the positive. And some of the people, they may not present with your polyarthritis. In the early stages, it could be present as a monoarthritis or oligoarthritis. Morning stiffness, you need not, the people may not have more than 1 hour. Some people may have the 15 minutes or 30 minutes. So high index of the suspicion is always needed, especially the females aged between 30 and the 50 years with a lot of the polyarthralgia or arthralgia, etc. So they decide to diagnose the rheumatoid arthritis. So detect early and treat immediately with DMRDs, not with your painkillers or the steroids. DMRDs should be started from the day 1 and tailor the treatment to the individual. So you need not treat with the 4 or the 5 DMRDs in most of the individuals, provided if you detect the early. Otherwise, when the disease is very established or very severe, so sometimes now you may start with the biologicals from the day 1 of your diagnosis. So these are all the key principles of the rheumatoid arthritis management. So why to treat early? Because of this picture. See, if you see here the inflammation, so the dotted lines, So the inflammation is more or less the same as the days goes on or the years pass on. But what happens to your radiological scores and what about your disability? So these two are proportionally increasing. So even though the inflammation is not that high, as the days goes on or the years goes on, but the radiographic changes, the erosions, the bone erosions, etc., osteoporosis, and finally the disability will score high. So that is the reason, even though from the initial days, even though the inflammation is not that high, we should aggressively treat rheumatoid arthritis like your diabetes or hypertension. For any chronic disease, so non-pharmacological treatment is there. So the diet, exercise, acupuncture, especially from Chinese point of view, even in the herbal medicines and other places, massages, stress reduction techniques, prayer, some meditation, hypnosis, yoga. So these are all plays a major role in the non-pharmacological management of the rheumatoid arthritis. The most commonly observed vitamin deficiencies or the mineral deficiencies in the patient with rheumatoid arthritis. So most of these people are anemic. So they are iron deficiency, folic acid deficiency. So they also have the vitamin deficiency like C, D, B6, B12, vitamin E, calcium, magnesium, zinc and selenium. So they need the supplementation at least 50% of rheumatoid arthritis in established and severe rheumatoid arthritis. In the early stages, they may not need these vitamins and the minerals. So being overweight strains the joints and leads to the further inflammation. This is a very, very important. So all the rheumatological patients, they should not gain the weight. So as the weight is increasing, so there are the high chances of having the osteoarthritis at a later stage. So osteoarthritis predisposing on your rheumatoid arthritis. It's a very, very common in the obese individuals. See, 4 times a week is not right. It's about 7 times a week. Not for 30 minutes, maybe 60 to 90 minutes. So the walking, light jogging, water aerobics, cycling, yoga, Tai Chi from the China, stretching exercises. So these are all very, very important. But the diet and arthritis, if you are overweight or the obese, so definitely the diet plays a major role in your weight loss. So reducing your saturated fats, reducing your trans fats, reducing your simple carbohydrates and reducing your sugars, etc., salt, oil, etc. You can reduce the weight. So as far as the diet is concerned. So antioxidants are very high in your green leafy vegetables, etc. So antioxidants are very useful for any chronic disease, not only in rheumatoid arthritis, all the chronic diseases you know of, it's very, very useful. Vitamin C is also useful as an anti-inflammatory and also immunomodulator and supplements in some population. So these are the exercises and the arthritis, water aerobics, walking, physical therapy, some yoga. And finally coming to your part. So we are the clinicians. So we write a lot of that. That's what to write. So NSAIDs, yes. Painkillers. Steroids, yes. Because a lot of the inflammation is there. DMRDs, yes. To reduce the disability and the deformities. So these are the sheet anchor of the drugs. Immunosuppressive therapy, yes. In aggressive cases. Biological therapies, yes. Your infliximab, adalimumab, rituximab, etc. And surgery in some cases like synovectomy, etc. So all these plays a major role in the management of the rheumatoid arthritis depending on the patient. Suppose if the patient is a very, very mild rheumatoid arthritis, even a short dose of the steroid and some elements of the NSAIDs may help them to achieve your remission. As a physician, so you should understand that all the pain individuals, they should first seen by the physician. You should behave like a basic rheumatologist. So you should decide whether this pain is because of the surgical pain or a medical pain. So most of the rheumatoid diseases, they are all the medical pains. Your rheumatoid arthritis, surgery role is only 1%. Your SLE, the surgery role is 0%. Suppose your systemic sclerosis, surgery role is 0%. So except in osteoarthritis, that to the severe osteoarthritis, the role of the orthopedic surgeon in the rheumatology is big 0. So that is the reason you should not allow any of your kids and kin or your family members or your friends for any pain. First they should address or they should consult a physician. So decide whether this pain is a neurological pain or a joint pain or a muscle pain or bursa pain or the tendon pain, etc., etc. and then act accordingly. So this is a very important take home point. So what about the NASIAs? So these are all individualized. See, some fellow, some Venkatrao is very happy with the paracetamol. Some Subbarao is very happy with ibuprofen. Whereas some Lakshman Rao is very happy with indomethacin. In the same way, so these painkillers, they are all individualized. Okay. So some people are very good response to the aspirin, some are with the ibuprofen, some with the naproxen, some with your celecoxib or retocoxib, or now recently we are getting the palmosave. So palmocoxib, etc. So depending on the patient's interest and the individual response, you can use these drugs. What was the clinical use? They are anti-inflammatory, used in the management of the inflammatory conditions. Antipyretic, so they use it to control the fever also, and they are also analgesic. But what about the side effects? These are the tremendous side effects, and all the physicians should know of these side effects. They cause nausea, they cause vomiting, they cause diarrhea. Some drugs may cause the constipation, nausea, dizziness, drowsiness, edema of the body, renal failure, hepatic failure, bleeding disorders, and ulcers. Gastric ulcers or that esophageal ulcers or the duodenal ulcers. See the set of the side effects we often see with the NASIAs. In spite of these, we rate a lot of the NASIAs left and right. If we prescribe for the 10 days, they take it for 10 months because they are very comfortable with the pain until they get some of these complications or some of these side effects. So these side effects are very, very common with the NASIAs. So don't prescribe the NASIAs for a prolonged period. So whenever you write an NASIAs to any patient, you should tell them that these are not the good drugs to be used for the long-term basis. This is for the short-term basis only. Whether I am available or not, you should consult another doctor to continue or not to continue. So this is the one piece of the advice you should give to all your patients whenever you prescribe the NASIAs for about 10 days or the 15 days or 20 days. I have seen few patients, they died because of the intestinal bleed, because of the gastric bleed, because of these NASIAD associated gastropathies, etc. So it's a very, very big problem once they get the side effects. So use cautiously in patients the treatment of the bleeding disorders because they do increase it. Encourage the patient to avoid the concurrent use of the alcohol, not only the alcohol, smoking also. The smoking and the alcohol will aggravate the side effects of the NASIADs. NASIADs may decrease the response to the diuretics or the antihypertensive therapy. So we prescribe a lot of the diuretics and the antihypertensive medications for our hypertension people, for our diabetic hypertension people, for our CKD population. We write a lot of the antihypertensive drugs, maybe 4 drugs or the 5 drugs in an established CKD. So today morning I have seen one CKD patient with the creatinine 4.5 and the blood pressure is 240 by 140. So I started prescribing the nifedipine 20 mg TID, Minipressel XL, 5 milligrams TID, Artemin BD, and also the torsemide 20 milligrams BD. So imagine how many drugs I have prescribed just to reduce the blood pressure. I am damn sure that in the next visit, the blood pressure still, it could be 160 by 100. Even though your target is 120 by 80, it is very, very difficult to reach the target in an established CKD population. So because not only the drugs, your salt restriction should help them. So these are all also very, very important. So the NASIAD therapy is a very, very one hand, very useful drugs. On the other hand, very worrisome drugs, provided if you continue for the long period. So this is a very important. So the gray zone, you should identify these people in these people with the NASIAD therapy. So they reduce the pain and swelling by inhibiting the COX. So at the data time, I will tell you what to mean by the COX-1 and the COX-2. What are all the advantages of the COX-1, disadvantages of the COX-1, advantages of the COX-2, and disadvantages of the COX-2. What are the drugs which act on the both COX-1 and the COX-2, which drugs act only on the COX-2. So in the next few minutes, we would like to talk on those things. These NASIAs, they do not alter the course of the disease. So that is a very important take-home point for all of you. So don't depend on the NASIAs and the rheumatoid arthritis because they don't alter the course of the disease. They don't stop the progression of the disease. They don't stop the aggressiveness of the disease. So this is a progressive, aggressive, and a dynamic disease, rheumatoid arthritis. So the NASIAs, they don't alter the course of the disease. A chronic use should be minimized because of the NASIAD side effects. Most common side effect related to the GI tract, very common in our Indian population, very common in our Godavari population. Because a lot of the people are the smokers and the alcoholics, and they take a lot of the non-vegetarian diet. Okay, so very preferably you write very few drugs of the NSAIDs. Otherwise, you exclusively write the COX-2 inhibitors like celecoxib. The next important drugs in the management of rheumatoid arthritis are the steroids. Excellent drugs. The best drugs in the management of the rheumatoid arthritis, for that matter, any rheumatological condition, any connective tissue disorders, tremendous drugs are the steroids. Again, on one hand, they are so useful. On the other hand, they are so dangerous. So I have seen few patients, they present with the Cushing's, your medical Cushing's. So with the diabetes, with the hypertension, with osteoporosis, with etc., with weight gain, obesity, these are all because of the steroid therapy. So you have the different cortisones is there, hydrocortisone, prednisolone, betamethasone, and dexamethasone. General use used in the management of the inflammatory conditions. So in all the inflammatory conditions, we use the steroids. When NSAIDs may be contraindicated, suppose in the gastritis population, so where the NSAIDs are contraindicated, you can use a small dose of the steroids to tackle the disease. Even though the steroids may also cause gastritis, promptly improve the symptoms of the rheumatoid arthritis. Excellent response. If you start with the Vicodin 20 milligrams BD or TID, so all the pains are gone for a short period. So what are the side effects? They gain weight because they increase the appetite, and water and salt retention, increase the blood pressure, increase the blood sugars, depression, mood swings, myalgias, osteoporosis are very, very important, especially when you are treating with the postmenopausal women. So osteoarthritis, rheumatoid arthritis is so common in the women. So in the perimenopausal period, so definitely if you prescribe the large doses of the steroids, so definitely high chances of having the osteoporosis. There you should prescribe a good amount of the calciums. Steroid therapy will delay the wound healing and onset or worsening of the diabetes. So again, a lot of the people we see rheumatoid arthritis and the diabetes. And the rheumatoid arthritis in the flare, in the aggressive form, where I have to use large doses of the steroids. The patient happens to be a diabetic. What about your fasting blood sugar, your PP blood sugar, your HbA1c? So the fasting will be 200, postpone will be 300, 400, etc. by starting your steroid therapy. So not the 5 milligrams of the Vicodin is not sufficient when the disease is very aggressive. So we need at least 1 mg per kg body weight. So there I have to use at least 60 milligrams to 80 milligrams. So then all the OHs stop and start with very intensive management of diabetes with insulin therapy. So basal bolus therapy. So morning before breakfast, give one steroid tablet, or prednisolone 20 milligrams and maybe 20 to 25 units of your regular insulin. Again, the before lunch you give the 30 or 40 units of the regular insulin. Before the dinner you give 20 to 30 units of the regular insulin. And at the bedtime you give the basal insulin, maybe the glargine or deglutec. See, so this is very, very difficult because unfortunately a lot of the people are having the both diabetes and rheumatoid arthritis. So the steroid therapy will definitely cause worsening of the diabetes. Sometimes if the patient happens to be a strong family history of the diabetes, even though the patient is not having the diabetes at this juncture, so after starting your steroid therapy in a rheumatoid arthritis individual with a strong family background, so these people will turn up into a diabetic in the next visit. Okay, so there you have to assess it. So this is the very important thing. So the nursing considerations: take medications as directed, adrenal suppression, use it with a caution in the diabetic individuals, encourage the diet high in the protein, calcium, potassium, and the low in the sodium and the carbohydrates. So the dietary approach, it's very easy to say, but no one follows. They discuss the body image. Discuss the risk for the infection. Discuss the body image means they gain weight gain. And obviously when the people are on the steroid therapy, so avoid the infections also, because it reduces the immunity. So steroids both systemic and intra-articular. So intra-articular steroids are excellent. But systemic steroids, they cause a lot of these side effects. Indications for the systemic steroids for the treatment of the rheumatoid flares That is the aggressiveness of the rheumatoid arthritis. Extra-articular rheumatoid arthritis. Suppose if the patient happens to be a rheumatoid vasculitis, so you have the distal gangrenes, so definitely there is a role of systemic steroids. And interstitial lung disease, again there is the role of steroids. A bridge therapy for 6 to 8 weeks before the action of the DMRDs begin. This is a very beautiful thing. So all the steroids, they act as a bridge therapy. You should understand what you mean by the bridge therapy. So from the day one you are starting the DMRDs, but they don't act. That will take all whatever, whether you prescribe the methotrexate or whether you prescribe the sulfasalazine or the leflunomide or the hydroxychloroquine, they take minimum 2 to 3 months for its therapeutic action. So meanwhile, so till the period where you are going to get the therapeutic action, you please take the usage of these steroids, because these steroids will act as a bridge therapy. From the day one, the patient will be asymptomatic. From the day one, the patient will be very comfortable by starting the steroid therapy. But one thing is very clear. So stop these steroids after 1.5 months or the 2 months or the maximum 3 months. So by that time when you stop the steroid therapy, your DMRDs will take over the action and the people will be very comfortable. Otherwise, if you keep on continuing the steroid therapy, so definitely a lot of the side effects will happen. That's what they are common, very common in our rural rheumatoid arthritis individuals. So even though I say that, suppose if I seen one patient of rheumatoid arthritis from the village today, I tell them that, so your rheumatoid arthritis is a moderate degree or severe, etc. So I have to prescribe the steroids. I am writing the steroids to you, but please don't use these steroids beyond 2 months or 3 months. Okay, even though you are very comfortable. So this is the very important piece of advice you should give to these people. Otherwise, in a diabetic individual, if they take the steroids for a longer period, they will end up with the diabetic ketoacidosis with a very high blood sugars. Maintenance dose of the 10 mg or the less of the prednisolone daily in the patient with the active rheumatoid arthritis. When the disease is very active, when ESR is 80, your CRP is very high. So that shows that the patient is an active rheumatoid arthritis. There you have to use even at least a 10 milligrams of the prednisolone. Sometimes I use even the 5 milligrams of the prednisolone. In some cases, I use even the 2.5 milligrams of prednisolone as a maintenance dose. But this is useful, this is needed in only few patients. Not all patients will need this maintenance dose of the steroids for a longer period. So when the disease is very active in longer period, so definitely you need prednisolone, maybe 10 mg or 5 mg or 2.5 mg. Otherwise, you always use these steroids as a bridge therapy. So you please remember the word bridge therapy in your rheumatoid arthritis. Sometimes in pregnancy, when other DMRDs cannot be used. Obviously, in pregnancy, we don't use the methotrexate. It's very much contraindicated. You can use the hydroxychloroquine in pregnancy. You can use the sulfasalazine in pregnancy, and definitely take the help of the steroids in the pregnancy. So then that's how you have to treat the rheumatoid arthritis in pregnancy. Leflunomide is contraindicated. Methotrexate is contraindicated. All the biologicals also we don't use in the pregnancy. We use just steroid, and if needed, we use the hydroxychloroquine and the sulfasalazine. So is the holding with your DMRDs range. Always touch the people, touch the arms of the rheumatoid arthritis, so they feel very comfortable, and then use these drugs. This is modifying anti-rheumatology drugs. So these are the very, very important drugs actually alter the disease course. Your steroids don't alter it. Your NSAIDs don't alter it, but they give the good symptomatic relief. But the drugs that alter the disease of this aggressive and dynamic and progressive disease are the DMRDs. They should be used as soon as the diagnosis is made. So once your diagnosis of the rheumatoid arthritis is there, so that is the time you are supposed to start the DMRDs, unless otherwise contraindicated. Like your metformin therapy in the type 2 diabetes. Obese individual, overweight, type 2 diabetes. So what drug you are supposed to prescribe? Unless otherwise contraindicated, metformin. So then you can add your SGLT inhibitors or your gliptins, or if the patient can afford GLP-1 receptor agonists, etc., etc. It should be used as soon as the diagnosis is made, appearance of the benefit delayed for weeks to the months. This is a very important take-home point. So don't expect the results within the few days of your DMRD therapy. You have to wait for a few weeks to the months. Maybe I wait at least for the 3 months. after starting my DMRTs in rheumatoid arthritis. I also tell to my patient, don't expect very drastic response with these drugs. You have to wait for at least 3 months. Meanwhile, take the steroids, and after 3 months or the 2.5 months, I would like to stop the steroids and will continue these DMRTs. These are the very important drugs for your rheumatoid arthritis in a long-term basis. NSAIDs must be continued with them until true remission is achieved. In the initial days, we have to prescribe all the three: NSAIDs, steroids, and also DMRTs. So in due course, NSAIDs you can stop at SOS basis. Steroids you can stop after 6 months, after 2 months, or the 2.5 months, or 3 months, and then continue the DMRTs in a chronic basis. Induction of true remission is very unusual, but luckily a lot of our people, they get the remission. Even though it's not a true remission, a lot of the people, they feel very comfortable with the DMRTs and the steroids and the NSAIDs, and then we can use the smaller amounts of the DMRTs when the patient is in the remission. What are the advantages? This is the most important advantage. You are being an inflammatory disease, rheumatoid arthritis, your PANS, your CD4 counts, your endothelial cells. So all these things in the physiology I have to show you the PANS. So this is the big inflammatory markers, your interleukin 1, 6, 12, etc. So it interferes with the inflammatory process. The PANS production will not be there, and the people will be very comfortable because the joints are also very comfortable. Your synovium is also very comfortable. Otherwise, there will be a lot of synovitis, etc. So once they interfere with the inflammatory process, they decrease the pain, they slow the disease progression, that is very important. They retard the development of the joint erosions, they improve the functional disability, and finally, and most important, is quality of the life. See the advantage of the DMRTs. So with this slide, I hope that you all people will agree with me to start the DMRTs from the day one of your rheumatoid arthritis individuals. Because DMRTs, again I'm telling you, DMRTs, they interfere with the inflammatory process, they reduce the pain, they slow the disease progression, they retard the development of the joint erosions, improve the functional disability, and last but not the least, improve the quality of the life. So these are the important DMRTs we often use left and right every day. Methotrexate sheet anchor, the best drug, once in a week, starts with maybe 15 milligrams. Some people may write 20 milligrams, some people will write 25 milligrams a week, once a week. Hydroxychloroquine, yes, 200 mg, 300 mg, 400 mg OD. Sulfasalazine, yes, starts with 500 mg OD, and slowly you can uptake to 1 gram BD. So 500 mg to 2 grams a day. Leflunomide, earlier we used to give 100 milligrams as the loading dose, followed by the 10 milligrams daily. Now the concept is use the 10 milligrams daily, whether the 10 mg or the 20 mg. 80% of the cases we use 10 mg. In some cases we prescribe 20 mg. Methotrexate and leflunomide are contraindicated in the pregnancy, whereas hydroxychloroquine, sulfasalazine can be used. In interstitial lung disease, again the methotrexate is contraindicated. Sometimes methotrexate may cause the lung problem. Almost looks like the interstitial lung disease. That is called methotrexate lung. Like your kidneys in hypertension. So hypertension, uncontrolled hypertension may damage the kidney, and chronic kidney damage may cause the hypertension. So cause and effect. In the same way, the methotrexate itself may damage the lung, or rheumatoid arthritis itself may damage the lung. So it is always a difficult question to say whether this lung lesion is because of the methotrexate or because of the rheumatoid arthritis. Sometimes it is very, very difficult. Nowadays we are not writing the chloroquine. When we were undergraduate, we used to write a lot of the chloroquines. Now the hydroxychloroquine is available, then we stop writing the chloroquine, because chloroquine will cause a lot of the side effects, like your retinal toxicity, ophthalmic toxicity, some gastritis, nausea, etc. They are all very common with the chloroquine, but not with the hydroxychloroquine. Gold, earlier we used to write a lot of the gold and the injectable golds. Now we are not writing it. Cyclosporin, yes, is the drug of choice for your renal transplantation individuals. Is an immunosuppressive drug, so that can be useful in some resistant rheumatoid arthritis where you are not getting the good response with the methotrexate and leflunomide or sulfasalazine, then you can use these drugs like cyclosporin A, like your MDR tuberculosis. So initially you are very happy with INH, rifampicin, pyrazinamide and ethambutol. But once it is MDR, so you stop writing these drugs, you plan for the second line of the drugs. In the same way, the cyclosporin is a very useful drug once the patient is having resistant rheumatoid arthritis. Dipenicillamine and bucilamine, minocycline, doxycycline, ravamizole. So doxycycline, minocycline, so tributes to Dr. Ella Pragad Subbarao, so who discovered wonderful drugs. He is from our Godavari people. Doxy and the minocycline. He studied in Rajahmundry, he studied in Kakinada. He is born and brought up in Narsapur, Bhimavaram area. So he is a very, very great scientist. One of the greatest scientists in our medical field is Dr. Ella Pragad Subbarao. So he discovered minocycline, he discovered doxycycline, he discovered your heterogen, diethyl carbamazine for your filariasis. And he discovered the DNA synthesis. He discovered the folic acid, very useful drug in OBG population. They always write the folic acid. So very great fellow, Ella Pragad Subbarao. So every day I write at least one prescription of the Ella Pragad Subbarao in my I have to write it. So once it's a rheumatoid arthritis, I have to prescribe the methotrexate. Once you prescribe the methotrexate, you are supposed to write folic acid. Folic acid. Okay. So in all the neurological problems, sometimes we write the folic acid. Okay. So doxycycline is a very good antibiotic in our COVID era. Even in the long-standing and the chronic antibiotic, we use the doxycycline in some cases. In all the filarial patients, we use the heterogen, diethyl carbamazine. Okay. Even the methotrexate is also invented by the Ella Pragad Subbarao. Methotrexate, folic acid. Great. Excellent. When to start the DMRTs? DMRTs are indicated in all patients with rheumatoid arthritis who continue to have the active disease even after the 3 months of the NSAID usage. The period of 3 months is arbitrary and has been chosen since a small percentage of the patients may go in spontaneous remission. So the vast majority need DMRTs and many rheumatologists start the DMRTs from the day one. So my concept is to trust the third sentence. Okay, not the 1 and 2. Because very few people will have the remission. From the day one, you start the DMRTs because it is a very aggressive disease and a progressive disease. There are no strict guidelines about which DMRTs to start first in an individual, but methotrexate has rapid onset of the action than the other DMRTs. Then that should be the drug of the choice, initial drug for most of our rheumatoid arthritis individuals. Taking in account the patient tolerance, cost considerations, because once in a week we use it, and compliance is also good, patient tolerance is also good, and ease of once a weekly oral administration. Methotrexate is the DMRT of choice, most widely prescribed in the world. In all over the world, the most widely prescribed drug is the methotrexate, invented by our Indian Ella Pragad Subbarao. Should DMRTs be used singly or in combination? Yes, your answer is for combination. Since single DMRT therapy in conjunction with an NSAID is often only modestly effective, combination therapy has an inherent appeal. I will show you a picture where combination therapy will help when compared to the monotherapy. DMRT combination is especially effective if they include the methotrexate as an anchor drug. So combination therapy means methotrexate plus something else. Methotrexate plus leflunomide, or methotrexate plus hydroxychloroquine, or methotrexate plus hydroxychloroquine plus sulfasalazine, etc. So combination are synergistic since mode of the action is the different. Obviously all these drugs, they act differently, and when you are using the combinations, you will gain lot of the effects like your diabetes management, your omnious octet, and you are using the different drugs. So methotrexate, the gold standard, gold salts, cyclosporin, sulfasalazine, azathioprine, etc. So they are immunosuppressive activity. They reduce the inflammation. They slows down the joint destruction and preserves the joint function. These two are very important things. Slows down joint destruction but preserves the joint function. See the lot of the side effects, almost like your steroid side effects. your dizziness, drowsiness, pulmonary fibrosis, pneumonitis, anorexia, nausea, hepatotoxicity, stomatitis, infertility, especially the sulfasalazine, they reduce the sperm count, alopecia, skin ulcerations, aplastic anemia, bone marrow suppression, thrombocytopenia, leukopenia. These are all because of your bone marrow suppression. Nephropathy, fever, photosensitivity. So for this fear, most of the doctors, especially our orthopedic surgeons, they don't prescribe the DMRTs. Always every visit they write the NSAIDs and the steroids. So, but you have to start the DMRTs from the day one. But you have to remember these side effects. So these are the very, very important side effects. Sometimes, troubleshooters. So see the organ which is spared in side effects of the DMRTs. No organ is spared, including your sperm count. Okay. So all these things. So some dizziness, drowsiness, headache, pulmonary fibrosis, pneumonitis, anorexia, nausea, hepatotoxicity, stomatitis, infertility, alopecia, bone marrow suppression, nephropathy, fever, and photosensitivity. So you should remember these side effects. In the next visits, in the follow-up visits, whenever the patient gets these side effects, you should think that these side effects is because of your DMRT therapy. So some of the people, though, when you are not knowing these side effects, when the fellow is presenting with the photosensitivity, then they refer the case to ophthalmologist or MRI or CT brain, etc. and etc. Okay. Hydroxychloroquine very cheap, 200 mg, 300 mg, 400 mg. So what are the side effects? Skin pigmentation is a very common with the hydroxychloroquine. Retinopathy. So once in a year, you screen for retina changes when the fellow is on hydroxychloroquine. Nausea. Some people they present with psychosis and myopathy. But skin pigmentation and retinopathy are so common with the hydroxychloroquine therapy. So fundus examination. Onset of the action, 2 to 4 months. So you have to wait for about 2 to 4 months, on average 3 months to gain the therapeutic action with your hydroxychloroquine. Methotrexate. So 5 mg is available, 7.5 mg is available, 10 mg is available, 15 mg is available, 20 mg is available, even 25 mg is also available. So depending on the body weight, depending on the severity of the rheumatoid arthritis, anywhere, usually I start with 15 mg in most of the individuals. Some people I start with 10 mg, some people I start with 7.5 mg, but my maximum dose is mostly the 20 or 25 milligrams a week. So they cause gastrointestinal upset, hepatotoxicity, bone marrow suppression, and pulmonary fibrosis. Okay. So monitoring, how to monitoring methotrexate therapy. So 4 investigations. One is the CBP is very, very important to know the hemoglobin, to know the RBC count, to know the WBC count, to know the platelet count for any bone marrow suppression, etc. And then the LFT, and then the RFT. So to rule out your nephrotoxicity and the renal toxicity, so get the SGPT, SGOT, and the urea creatinine. So when the phero is very poor, we write the CBP, SGPT, creatinine. Okay, so these are very important drugs. So onset of the action again here is a rapidly acting DMRT. So 1 to 2 months. Within 1 to 2 months you may get it. But usually it may take 2 to 3 months for methotrexate also to get the onset of the action. Sulfasalazine. Always start with 500 mg only, like your metformin. You can go up to the 2 grams. Side effects rash, myelosuppression, may reduce the sperm count. Monitoring the blood counts on the LFT. Onset of the action 1 to 2 months. Leflunomide, very useful drug. Very useful drug in some individuals. So loading dose, no, we are not giving it, but every day we give 10 milligrams or 20 milligrams. So nausea, diarrhea, alopecia, and hepatotoxicity. LFT, at least once in 2 months or 3 months. And onset of the action 1 to 2 months. Okay. So same thing here, the methotrexate. See the comments. and the mechanism of the action. So methotrexate, first one, anti-metabolite, DNA synthesis inhibitor. DNA synthesis inhibitor and anti-metabolite. What are the comments? Rapid onset tends to produce more sustained results over the time than other DMRTs and lowers all-cause mortality. It can be combined with other DMRTs or the biological therapy. It is almost like your metformin in diabetic management. Metformin plus sulfonylurea, metformin plus other drugs, etc., etc. In the same way, you combine the methotrexate with all other DMRTs. Leflunomide, they inhibits the pyrimidine synthesis, DNA synthesis inhibitor. What about the comments? They improve the multiple clinical outcomes and delays the radiographic changes. Can be eliminated from the system with the cholestyramine in patients wishing to conceive. See, this is very common in the women when they are getting before the conception rheumatoid arthritis, and they are forced to write these leflunomide. When the fellows are very eagerly interested to conceive, then definitely have to stop using the leflunomide and start using the cholestyramine to make all the leflunomide in the body to be washed out. So it's a very, very important thing. So that is the reason we don't prescribe the leflunomide in recently married and girls. In them, you can use the sulfasalazine or hydroxychloroquine or the steroids till they conceive, until they get delivery. After that, you can use all these drugs. Yes, pregnancy among the DMRTs, sulfasalazine, hydroxychloroquine treatment may be maintained. Lactation, prednisolone, sulfasalazine and hydroxychloroquine may be used cautiously. Liver disease and alcoholics, hydroxychloroquine is safe. We are not using the gold. It's not available right now because the cost of the gold is very high. Touches 1 lakh. Renal disease, paracetamol may be used. Hydroxychloroquine, sulfasalazine may be used. Here again the leflunomide and the methotrexate are contraindicated. On lung disease, again hydroxychloroquine and sulfasalazine and leflunomide can be used safely. So in a single word, the most toxic drug is the methotrexate, and then next one is the leflunomide. And safest are the sulfasalazine and hydroxychloroquine. But activity wise, highly potent drug is the methotrexate and leflunomide. So immunosuppressive drugs, methotrexate, most effective, single DMRT, good benefit to risk ratio. So as a country like India, where the money matters a lot for our rural Indians, so definitely the methotrexate helps them a lot because of the once a week therapy. Azathioprine, yes, we use it in some, especially in the interstitial lung disease, and the fellow is having the extra-articular manifestations. It is available in the 50 milligrams azathioprine. Slow onset and reasonably very effective. Cyclophosphamide, yes, we give it as a pulse therapy again in the people with the vasculitis. When the people present with the gangrenous, etc., so definitely the drug of choice is the cyclophosphamide. Cyclosporine, yes, superior to the placebo, but the renal toxicity. So the creatinine level should be normal to use the cyclosporine. So all these drugs we often use because once you are treating a lot of the rheumatoid arthritis, so obviously you get a lot of the referrals also. So in those people, when the people may be having the renal toxicity, some people may have the hepatotoxicity, some people are the resistant rheumatoid arthritis where your hands are tight in using the traditional DMRTs, then you are supposed to prescribe the azathioprine, you are supposed to write the cyclophosphamide, you are supposed to write the cyclosporine. So these are the very useful drugs and very aggressive drugs, very good drugs to be treated in some of our rheumatoid arthritis individuals. See this picture, a beautiful one, the triple therapy. See the response, nearly 80%. So the methotrexate, hydroxychloroquine and sulfasalazine, that is the best triple drug therapy in our patients. Superior to any one or two alone. Side effects no greater, not of much side effects. Even though you prescribe the 2 or the 3 DMRTs, you are not increasing the side effect profiles. See again, triple drug therapy, 77% get 50% improvement. Methotrexate monotherapy, 33% response. How to monitoring the treatment of the diabetes? So these drugs need the frequent monitoring. This is the very important. So you have to talk a lot with the rheumatoid arthritis after prescribing the diabetes. Monitoring is very important. Follow-up is very important. Otherwise, these people may die prematurely because of the side effects, because of the hepatotoxicity or rhinotoxicity or bone marrow suppression. So they may live long, provided if they don't take the DMRTs. After taking the DMRTs, if they did continue the medication and they were very poor in your compliance, very poor in the follow-up, so definitely they get a lot of the side effects. Blood, liver, lung and kidney are frequent sites of the adverse effects. Interval of laboratory testing varies with the drug. Usually I prescribe, I read the drugs for the 3 months, and once in a 3 months, ask them to get the CBP, LFT and RFT, and accordingly I adjust the dosages. But fortunately, 80 to 85% of our population, they don't develop any side effects or any hepatotoxicity or rhinotoxicity, etc. I have few people who comes once in 6 months or once in 9 months or once in a year, keep on using the methotrexate, etc., in spite of my repeated requests, but luckily they are not getting any side effects. Okay. Most patients, they need to be seen 3 to 6 times a year, but at least you have to see at least 3 times a year or 4 times a year. So this is the beautiful slide showing you the adverse effects of the diabetes. So as a physician, you should know, see the hydroxychloroquine, maybe a little bit on the eye and the hematological. It is very, as far as the liver is concerned, lung is concerned, kidney is concerned, very safe, hydroxychloroquine. Whatever the sulfasalazine. So they may cause the bone marrow suppression, maybe hepatotoxicity, and sometimes lung fibrosis, and gastrointestinal side effects are very common with the sulfasalazine, because you have to use the higher dose of the sulfasalazine for your therapeutic actions, not the 500 milligrams OD, maybe 1.5 to 2 grams a day. So obviously they cause gastrointestinal side effects. Gold we are not using now. Methotrexate, useful drug, but they cause bone marrow suppression, they cause hepatotoxicity and lung fibrosis, and then renal sometimes, infections very common, and mucositis. Azathioprine, pancreatitis. Cyclophosphamide, cystitis. Tumor necrosis factor inhibitors. The local leflunomide, see the leflunomide, hepatotoxic and also bone marrow suppression. So these are the very important side effects. So when you are prescribing the drugs, you should remember these side effect profile. So azathioprine, as I told you, they have the side effects and myelosuppression and infection. Usually use 50 milligrams OD. Some people, when they are very obese, I use 100 milligrams OD. Cyclosporine, nephrotoxic, and the cyclosporine induced hypertension, that is also there. So in all the visits, when the fellows are on the cyclosporine, 2 things are very important. Record the blood pressure by yourself. Otherwise, our sisters always say 120 by 80, 120 by 80. If you record the blood pressure, it will be 180 by 110. Okay. And then renal functions, urea, creatinine and potassium. Cyclophosphamide, myelosuppression, gonadal toxicity, hemorrhagic cystitis and bladder cancer. See how they act, where they act. Hydroxychloroquine, T lymphocytes. Target of activity is T lymphocytes. Your methotrexate, dihydrofolate reductase and folate metabolism. So that is the reason we always prescribe the folic acid along with the methotrexate. Leflunomide, pyridine synthesis. Sulfasalazine, exact cause is not known, it's a multifactorial, including the impairment of the lymphocyte function and the cytokine synthesis. What are the limitations of the conventional DMRTs? So onset of the action takes the several months. That is the biggest limitation. It's not as rapid as your steroid therapy or your NSAID therapy. They are very comfortable with this therapy. But as far as the long-term results are concerned, DMRTs are very useful. The remission induced in many cases is very partial remission. substantial toxicity which requires the careful monitoring is very important. DMRTs have a tendency to lose the effectiveness with the time. So this is a very important, like your secondary sulfonylurea failure. So the people's blood sugars will be very good control with you, even with your glimepiride 1 mg or the 2 mg in the initial days. After that, whatever the drugs of OHS you prescribe, so still the blood sugar will be fasting 200, postprandial 400, where you have to prescribe the insulin. So the same thing happens with the DMRTs also. Initial days, even the 10 mg of the methotrexate or 15 mg of methotrexate, the people will be very comfortable. These drawbacks have made the researchers look for an alternative treatment strategies. They are biologic response modifiers. They are the game changers in the management of the rheumatoid arthritis. Biologicals, you have the tumor necrosis factor inhibitors, say like infliximab, adalimumab, golimumab, etc. And interleukin 6 inhibitors, we used it in the COVID era, tocilizumab, beta cell depletion, rituximab, and we don't use the abatacept. Okay. So common the biologicals we often use in our practice are the rituximab, tocilizumab, infliximab, adalimumab. See, the anti-TNF medicines have revolutionized the treatment for the rheumatoid arthritis. It's a big game changer. So the data, the name given to this data is the premier. So the name given to this study. They are encouraging because they suggest that early and aggressive treatment may slow, not only slow, inhibit the patient's joint damage. So that is the beauty of these biologicals. They inhibit the patient's joint damage provided if you use them early and aggressive treatment. So these are all the BRMs, that is the biological response modifiers, infliximab, etanercept, adalimumab, anakinra. Traditionally, cytokine antagonists are indicated in the resistant RA with the active disease, but now we are prescribing even in the not a resistant one, even in the an established and a severe rheumatoid arthritis, even there is not a resistant, we use them as the initial agents of the choice, provided if the patient can afford. What you mean by the resistant RA? A failure of response to at least 2 DMRTs used in the optimal dosages for an adequate period, at least 6 months. So the good dosages of your 2 DMRTs, like your methotrexate, maybe 20 mg or 25 mg, once in a week, and then the sulfasalazine, 2 grams a day for at least 6 months. If you are not getting the good response, then it is a resistant RA. I am damn sure that most of our RAs are resistant RAs. Even if you use the 3 drugs, most of the cases I use 3 drugs, 3 DMRTs. Still, the patients are still having the active disease, lot of the erosions and a progressive disease. So there is always a choice, always a role to use these biological response modifiers in our population. Nearly 20 to 40% patients may not respond to the BRMs. Even though you prescribe the biologicals, in some people they may not respond. But this is not that high, 20 to 40%. Maybe 10 to 20% of the people they may not respond to the biologicals also. See, they used in the management of the inflammatory conditions. When the NSAIDs are contraindicated, promptly improve the symptoms of the RA, the same side effects. So this slide I showed you in the last week. Your CD4 T cell targeting, endothelial activation, macrophages, B cell activation, and finally the Fanus formation. So these cytokines, they are the key mediators of the immune function. It's an immune disorder, and you are using the mediator of these immune functions like your biologicals in rheumatoid arthritis and have been major targets of the therapeutic manipulations in the rheumatoid arthritis. Of the various cytokines, tumor necrosis factor alpha has an attractive maximum attention. So what are all the biologicals approved? Anti-TNF agents like infliximab, etanercept and adalimumab, all 3 are available in India. IL-1 receptor antagonist anakinra, I am not sure of this drug, but tocilizumab is available. we used a lot in our COVID era. Anti-CD20 antibodies, they are also very available, rituximab. So the rituximab, tocilizumab, infliximab, etanercept and adalimumab, they are widely available and we are all using these drugs for our patients of active rheumatoid arthritis or in resistant rheumatoid arthritis. So the infliximab, it is a 3 milligrams per kg IV infusion at weeks 0, 2 and 6. So give one injection today and ask them to come after the 15 days and then ask them to come after the 1 month. So 0, 2 and 6, excellent response. Followed by the maintenance dosing every 8 weeks has to be combined with the methotrexate. So continue the methotrexate, add the infliximab, 0, 2 and the 6 and then once in 2 months. What are the side effects? Most of these drugs are very tolerable. Some people, they may develop the infusion reactions. Increased risk of the infection because you are modulating the immune system. So definitely these people will have the infections. So that is the reason before you start these biologicals, we ask the patient to get the 3 tests. One test is Manto, another test is quantiferon gold, and the third one is CT chest. So get the Manto, quantiferon gold and the CT chest to rule out any latent tuberculosis. When the fellow is having the latent tuberculosis, unless you decide them or diagnose them, and you start writing these biologicals, these people will have an active tuberculosis afterwards. So this is a very important, three investigations are very important before you start the biologicals. Even though the patient says that I am affordable, give one injection of biologicals today, doctor means, no, you have to wait for at least 1 week. So get the Manto, read it after 2 days and send the blood for your quantiferon gold. So you may get the report after 2 days or the 3 or 4 days and then get the CT chest. So when all the 3 investigations are normal, negative, then you are an eligible candidate to get the biologicals. Suppose any one of these investigations is positive, then he is not a candidate to get the biological injections. The same thing to the adalimumab. These are very, very useful drugs. So they are the target of the activities. Adalimumab, human necrosis factor alpha. It is available in the doses of 40 milligrams. Earlier, these injections are available at the cost of 30,000 rupees a injection, 40 mg. Now it is available at the cost of 7,000 to 8,000 if you write it on your paper. Okay. So pass on this benefit to the patients. So I tell my patients that even though the price is 30,000, you will get it for about 7,000 to 8,000. So I will ask my sister, my personal assistant, to contact the respective representative. So give the phone number of that representative to that particular person. So the representative will tell to that person that the drug may come to the doctor's pharmacy in about 1 day or 2 days or 3 days. So at the cost of maybe 7,500 or 8,000 or 7,000. And then he pays that amount and then he gets the drug and then we'll give it. Suppose if he goes to any other shop, it will be costing about 30,000 rupees. So the adalimumab 40 mg, excellent drug, very good response. The same thing happens to almost all the drugs. So this is the very important slide, shows you the mild, moderate and severe. So as a beginners, you should know what to do with the mild disease, what to do with the moderate and what to do with the severe disease. What you mean by the mild disease? Meet the ACR criteria for rheumatoid arthritis. You know the criteria, 4 out of the 7 or 10 or 6 out of the 10, etc. And have some of the following clinical features. Arthralgias, yes. At least 3 inflamed or the swollen joints. Good. No extra-articular disease. Only arthritis, only 3 joints. A negative or a positive rheumatoid factor test. RA may be negative, RA may be the positive. Elevated ESR or the serum concentration. So there is an elevated ESR, elevated CRP. No evidence of erosions or cartilage loss on the plain X-rays. So X-rays are the norm. So that's how the case can be considered as a mild disease. Mild disease means arthralgia, a few joints, X-ray normal, your ESR and CRP just elevated, and your rheumatoid factor could be the negative or maybe the slightly positive. So then you consider this as a mild case. What we mean by the moderate disease? So some combination of the following clinical features. between 6 and 20 inflamed joints. So the number of the joints here is nearly 20. So 6 to 20 joints. Absence of the extra-articular disease. So again here, absence of the extra-articular disease. Your lung is normal, no fibrosis. Your liver is normal, no hepatotoxicity. Kidney is normal, no proteinuria or not elevated creatinine levels. Retina is normal, eye is normal, skin is normal. So no extra-articular disease. Like even the nodules are also not there. Elevation in the ESR or the serum CRP concentration, but it is much more higher than your mild disease. Here the positive RF or anti-citrullinate peptide antibodies. No negativity. Here always RF factor is always positive and also anti-CCP is also positive. And evidence of inflammation via plain X-rays. So plain X-ray is also not normal. So plain X-ray is abnormal, shows some erosions, some inflammations in the bone, and then the values are little bit elevated. All are rheumatoid factor positivity, but only one exclusion here is absence of the extra-articular disease. So this is the moderate disease. Now the severe disease. What is severe? More than the 20 joints. So 3 joints or 4 joints or 5 joints is the mild. 6 to 20 joints is the moderate. More than 20 joints is the severe disease. A rapid decline in the functional capacity. So functional capacity is reduced. Whereas in the mild and moderate, not much reduced. Elevated levels of the ESR and CRP. Anemia of the chronic disease. So this is very important. Not only the anemia, hypoalbuminemia. So anemia and hypoalbuminemia says that the disease is very severe. Very severe. So when the patient is in the disarmity or the disabilities or functional disturbances, so definitely you write the protein levels also, serum proteins. So the serum protein shows albuminemia, hypoalbuminemia. That means the disease is very severe. A positive rheumatoid factor test under anti-citrulinated peptide antibodies, the anti-CCP antibodies. See the joint X-rays, rapid, demonstrating the rapid progression. So definitely there is a lot of ulnar deviation, aggressiveness, etc. and extra-articular disease. So extra-articular disease, bony lesions, lot of elevations, lot of the markers, and the patient is very aggressive and functional disability. So obviously the patient is in severe disease. So the activity based on patients and the physician assessment of the symptoms and the functional status, evaluation of the joint involvement and extra-articular manifestations, laboratory markers, and X-ray changes. So when the patient is in effort, even the MRI also. MRI will pick up the changes much early than your conventional X-rays. Symptoms and the functional status, degree of the joint pain, duration of the morning stiffness, severity of the fatigue, evidence of extra-articular manifestations, and self-report questionnaires. So the physical examination, investigations, imaging techniques like plain X-rays of the hands and the wrists, CT, ultrasonography, and MRI in some cases. General management strategy challenging in some cases. DMRDs as soon as possible. Aggressive treatment. Reasonable goal that escalate the intensity of the treatment until the evidence for the synovitis diminishes or disappears, or until the drug-induced side effects become the intolerable. So this is a very important reasonable goal. So keep on increasing the dose provided the patient is not happy with the symptoms. So you think that the disease is very aggressive, so keep on increasing the dosages of your conventional DMRDs and add and multiple DMRDs also. So therapeutic options, optimal therapy needs to be individualized, non-pharmacological and preventive treatments, pharmacological agents, and some people they may require surgical synovectomy also. So education, counseling, rest, exercise, physiotherapy, occupational therapy, nutrition, diet, and bone protection, because these people will have osteoporosis and osteopenia. So this is the combination therapy. Selection of the DMRD combinations often employed, sulfa and hydroxychloroquine, sulfa and methotrexate, hydroxychloroquine, etc. Monitoring of the drug toxicity, already I told you. End-stage disease. So goals of the therapy. Pain relief, protection of the remaining articular structures, maintenance of the function. Non-pharmacological interventions are particularly important here. Indications for surgery, intractable pain, severe functional disability due to the joint destruction, wear, transplantation, impending tendon rupture. Timing of the surgery is often very critical in some cases. Even though we say that surgery is helpful, but most of the people, they don't listen our words. And in some of the families, no, they almost looks like a destitutes. No one cares for them when the disease is very aggressive. So this is a very important one. See, treatment strategies. See, diagnosis of the RA is there. When there is no contraindication to the methotrexate, use it. When there is a contraindication to the methotrexate, use the other drugs like hydroxychloroquine and sulfasalazine. Plus or minus steroids in the center. So response is there, continue. If there is no response, then go to the phase 2. So the phase 1 is you are diagnosing the RA in your clinic, in your OPs. And you think there is any contraindication to the methotrexate or not. If there is no contraindication to the methotrexate, use the methotrexate. If there is a contraindication to the methotrexate like your liver toxicity or renal toxicity or the pregnancy, then use other drugs. And then take the help of the steroids or the NSAIDs for the time being. When the patient is responsible, continue the same treatment. When the patient is not responsible in the follow-up treatments, then you go to the second one. So what is here? Here the factors predisposing to the severe rheumatoid arthritis or no factors predicting the severe rheumatoid arthritis. So and switch to the other 3 MRTs. Like when the fellow is on the methotrexate, etc., switch to the other and very combination and straight away can go for the biologicals also. So usually I start with the methotrexate, etc., and then immediately I go to the biologicals in the next visit. When the patient is not getting the good response after 2 months or the 3 months, wait for at least 3 months to 6 months to choose your biologicals. And then the good response, okay. If the no response is there, then change the other biologicals and change other drugs, etc. So measurement of the disease activity. This is the DAS 28. So DAS. DAS means disease activity score. Do you have the surgical methods? Surgery, clinical methods, DAS. So here DAS means disease activity score. So it includes tender joint count, swollen joint count, ESR, patient global disease activity assessment. So depending on that, DAS activity, low means less than the 3.2, moderate means 3.2 to 5.1, very high means more than the 5.1. You need not remember these things, but DAS is disease activity score depending on the tender joints, on the swollen joints and the ESR. Suppose if the joints tenderness is very high, the swollen joints are very high, ESR is very high. So is the disease activity severe or mild? Obviously severe. So when there is no tender joints, when there are no swollen joints, when the ESR is very low, then the disease activity score is low. The disease is in the mild, is in the remission. So thus requires the 4 simple inputs. So 28 tender joints, out of them how many are there? 28 swollen joint count, out of them how many swollen? ESR and general health assessment of the patient on a VAS from 0 to 100%. So how will you are comfortable? Your quality of life, out of the 100% marks, how many marks you give it to your quality of the life? Is it 70% or 80%, 90%, depending on your movability, etc. So this is the chart we often give it on the patient. So activity, see all the joints involved there. The shoulder joint, elbow joint, wrist joint, proximal, metacarpophalangeal joints, proximal interphalangeal joints, no distal interphalangeal joints involved here. Knees are involved here. No foot joints are involved here. That's how we have to prescribe it. So these are the scores. Monitoring, already I told you. Disease activity is assessed by several parameters. Duration of the morning stiffness, tender joint count, swollen joint count, global assessment, patient global assessment, visual analog scale, so etc. Remission. The goal of RA treatment is no longer to simply control the symptoms, but to eradicate the inflammation. This is the beauty of the rheumatoid arthritis treatment. So the patient came to you as a physician purpose. So because you are the person to give them a remission. So to reduce, eradicate the inflammation. So eradicate the formation of the pannus. So to target the DMR, there is no signs of the active inflammation, no swollen joints, normal ESR or CRP, little or no radiographic progression. How long should it be continued? Once remission is achieved, maintenance dose for the long period is recommended, like your chronic disease, lifelong, but at a very minimal dosages. So relapse occurs in 3 to 5 months, 1 to 2 months in case of methotrexate, if drug is discontinued in the most instances. Lot of the people know, they themselves stop taking the drugs once they got in the remission. So within after 6 months or the 1 year, again they come back after 1 year or the 2 years to me. ఏమయ్యో లక్ష్మి 1 year నుంచి రాలేదంటే మీరు ఇచ్చిన ప్రిస్క్రిప్షన్ చాలా బాగుందండి, ఒక 3 months తర్వాత I feel very comfortable and then stop coming to you. So after 9 months or the 8 months of the stopping of the treatment, again they got the disease. So that means again now remission, exacerbation, and flare-ups and the remissions. So this is the very common in rheumatoid arthritis. DMRTs are discontinued with the patients because of the toxicity or the secondary failure. So this is the one case, a 34-year-old woman with a 5 years history of the rheumatoid arthritis. Very common, typical our patient, 34 years, 5 years history of the rheumatoid arthritis. Morning stiffness 30 minutes. Synovitis in the swellings of the MCP, PIP, wrist and metatarsophalangeal joints. Normal joint alignment. Rheumatoid factor is positive. X-rays are normal. No erosions on the X-rays. Is it a mild disease or moderate or the severe? Mild disease. So current activity is mild. No sign of damage after 5 years. Type 2 minimally progressive course. Even after the 5 years history of the rheumatoid arthritis. So the disease is so mild. So lucky. She is a lucky woman. So the treatment, NSAIDs, hydroxychloroquine, sulfasalazine, and education, etc. or physiotherapy. Another case, 34-year-old woman with 1 year history of the rheumatoid arthritis. Here, 1 year only. Morning stiffness 90 minutes. Synovitis 1 to 2 joints, MCP, PIP, wrist, knee and MTP. Normal joint alignment. RF is positive. Small erosions of right wrist and the 2 MCP seen on the X-rays. So X-rays showed the erosions. Factor is positive. And then synovitis in the many joints. And the morning stiffness not 30 minutes in the like earlier case. Here it is about 90 minutes. And even though the history of the rheumatoid arthritis is 1 year. So is this mild or moderate or severe? So definitely not a moderate, not a mild disease. Almost like a moderate to the severe disease. So here you have to prescribe the day 1 to DMR. See the X-ray here. See the early erosion at the tip of the ulnar styloid. Already erosion started. So very aggressive treatment is needed here. Otherwise these people will have disability and dysarthrias. See soft tissue swelling, no erosions, A. That should be our motto. But see the B and the C. So the B, thinning of the cortex on the radial side and minimal joint space narrowing. Already narrowing has started. And there is a thinning of the cortex on the radial side. And the C, so marginal erosion on the radial side with a joint space narrowing. So most of our people, they present like on the C. But our aim is, all our early rheumatoid arthritis, they should live with A picture. So moderate disease activity here, the treatment should be more aggressive. Like NSAIDs, methotrexate, sulfasalazine, hydroxychloroquine would be a good choice. Another case, 34-year-old woman, all three are 34 years. One fellow with 5 years, another fellow is 1 year, now this fellow is with 3 years history. Morning stiffness, 3 hours. So all the joints are involved here, metacarpophalangeal, proximal wrist, etc. There is ulnar deviation, swan neck deformity, decreased rotation of the movements of the wrists, nodules on the elbows. Is it aggressive or small? Very aggressive disease, very aggressive. Look for extra-articular manifestations also here. So RF is positive. X-ray shows erosions on the wrist and the MCP joints bilaterally. Currently on the low dose prednisolone, methotrexate, sulfasalazine and hydroxychloroquine. Already the patient is on 3 drugs. Methotrexate, sulfasalazine, hydroxychloroquine. But also on the low dose prednisolone. But still the disease is very aggressive. So what to do? What to do? Good, biologicals. So your answer should be a biological. Then I stop here. So these are all the gastropathies. See the COX-1 and the COX-2. See the subluxation of the cervical spine. RA can cause an asymptomatic instability of the neck. Manipulation under anesthesia can cause spinal cord injury. So all the rheumatoid arthritis patients should warn to the patient whenever they have any general anesthesia. So definitely they should tell to the anesthetist about my known case of rheumatoid arthritis. So then they take care of this atlantoaxial joint subluxation. See the NSAID therapy. DMRTs have a dark side. Methotrexate may cause serious problems like lung, liver, and bone marrow. Methotrexate lung. So this is a good slide. It makes a creaking and popping sound every time I get in or out. Very common with rheumatological problems. Okay. So surgical approaches are also there. These are all the summary. So this is the last slide. Take home messages. So dear postgraduates, rheumatoid arthritis is the commonest inflammatory joint disease seen in the clinical practice, affecting approximately 1% of the population in India. Imagine 140 crores to 150 crores population. So very big disease, very common disease, very often you see in the OPs, but yet we miss them. We miss them. From tomorrow onwards, you please check all the pains patients, joint pain patients. Ask about your morning stiffness. See the hands, see the metacarpophalangeal joints, see the proximal interphalangeal joints, see the knee joints, see the rheumatoid nodules, etc. and etc. Okay. Female is to male is about not 3:1, maybe 8:1 or 9:1 here. Small joints of the hand and feet are typically involved. A score of more than 6/10 is needed for classification of the patient as having definitive RA. Treatment should be started much early and should be individualized. Conventional DMRTs are useful first in the RA. If inadequate response to the conventional, then the biologicals are used. Sometimes you can straight away go for the biologicals, provided the disease is very severe. The most preferred biologicals in rheumatoid arthritis are TNF inhibitors like adalimumab, etc. Thank you.